I'm not a medical professional. Maybe this will be a little flashback at the start, but yeah, not a doctor.
Not a doctor.
Pardon me. Hi friends! Oh, welcome back to the Chronicles podcast. If you're new, hi, my name is Becca. I just nearly popped my wrist out of my socket, which is one of the fun things that happens to me. My knee's also hypermobile, and that likes to pop and crack. And that's the one knee that I have because I also have one leg. I'm a wheelchair user right now. I don't have a prosthetic. And if you're watching me on YouTube, these lashes look a bit wild today. But anytime, I'm shook, Simba's just opened the door behind me, so I guess that's going to be my background for today. I have tried to do this introduction 3 times because my audio's been off, the camera hasn't been right, I've had to do things with getting my juice. Now Simba's meowing, there was dogs barking outside and people shouting, and I just want to get this recorded today, so here we are. In the last episode, I hinted that this episode was going to be discussing mental health medication, my experience with medication, but also a bit of a look at an overview of medication, given a bit of perspective from me being a nurse and the kind of things that I learned, and hopefully you find it interesting because I quite liked doing my notes for this episode. I got my little book out that I used in uni that had all of my medications, and I went a wee bit too much into detail for this episode could easily have been a few minutes long, but I've shortened it a bit down and taken out all of the stuff that my brain was interested in, but I know that the wider population might not be interested in it. So let's get into today's episode, see how long I ramble on for. I've probably got some other bits of the introduction to do because I've just turned on the camera and started recording and not even looked at my notes. So let me do this, see if I've forgot anything. And yeah, happy Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. Oh, I don't know what day I'm going to be posting this. So there you go, have a little boogie, whatever day it is. I hope you're having a good day. And it'll be a split second for you, but I need a minute to collect myself because clearly there's something going on today in my noggin. Notes. Okay, so now that I've got my notes up and I'm a bit centred on what I'm actually doing, staring at this bright light, wow, I'm so distracted today. It's like 4 o'clock. I really thought I would be recording this at like 12, but time just got on and here we are. At least I'm sitting in front of the camera. I'm doing it. So in the last episode I said quite a few times that there was some stuff that I was going to discuss in the next episode, and here I am. You can probably hear Simba running about behind me, meowing with his little bell, and I try to kind of silence it as much as possible, but I'm waiting for a new wheelchair, and every time I move, this is the noise my chair makes. So I do try to not move very much when doing these episodes, but I've got a heat pad on my back today because I'm a little bit sore, and yeah, I'll try and keep the noises to a minimum, but who knows, it's coming to time for people being home. There's probably going to be Waynes and dogs and Simba continuing to scratch away in the background. So throughout university, we didn't get actually a lot of training and classes about medication. It was more through placement that we learned on the job. And I think we maybe got a medication booklet from the uni that we had to fill out to show our learning on placement, and maybe 1 class on mental health conditions and 1 class on medication. So when I say in uni it was a very small amount, it was a very small amount, but other than thinking of the nursing perspective and giving a bit of background on my learning about medications, side effects, different types, I am going to be sharing my own experience so far with trying to find the right medication for my brain. And yeah, I hope you enjoy today's episode, and always, if you do, give this video a like, follow me if you would like to hear more from me about my life experiences in mental health, disability, and general tomfoolery. I've never really used that word and it feels a wee bit too posh, but I don't know, that's just what came out. If you would like to see some shorter clips of the podcast, if you're not quite into long form content but you still like to hear me chat and shit, give me a little follow on TikTok at Chronicles Pod, and Instagram is the same. Anything that you would like to tell me about this week's episode, you can leave me a comment on YouTube, or if you're listening, you can drop me an email to crippledchroniclespod@gmail.com and I'll respond to you. Or if there's something you want to share on the podcast, just let me know and I will share it. And finally, like I said, if you're listening and you want to email, if you enjoy listening to the podcast instead of watching it on YouTube, maybe you found me on YouTube, but these are also available on the major listening platforms. Literally just need to search for Cripple Chronicles Podcast. Remember, give it a like, subscribe to get notifications, whatever you do on audio platforms, it is much appreciated. And I am going to swoop right into this week's episode and end the introduction here because it's gone on longer than I thought it would, which seems to be a theme with episodes, but I'm not going to complain because if I can just chat away and it creates content, then that makes me happy, and I hope it makes you happy too. Anyway, Becca, shut up and get on with the episode. Enjoy! I said that like I'm saying bye. Oh my gosh! I gave a little bit of foreshadowing in that long introduction that I was going to spend a little bit of time talking about my nursing training in terms of mental health medication. I'm going to try and not get too sidetracked or go off on too many tangents from my notes, but there's lots to say, and as from the introduction, sometimes I really just can't help myself when I start talking. I used my little notebook and making my notes. I don't know if it was in this recording or the other recording that was really pitchy that didn't quite work out, but I had a little notebook of all of my notes about medications, and this is how I've basically done my notes for this episode. It was mostly on placement. My memory was not the best before I had the accident, but when you are training as a nurse, you're spending roughly 40 to 48 hours a week on a ward doing medications, morning, afternoon, tea time, 24 patients, so a lot of the time you get very used to it, but I had to kind of brush up on what I wanted to talk about because I have been away from the world of nursing for 5 years now, and I only really got to dip my toe in before they were chopped off. Pardon me, that was perfect timing, and I'm actually drinking water today because I'm trying not to burp as much. But I have another one that I need to get out before I start doing this. Oh, that was a good one. These are all staying in because this is just me. Okay, so if you are new to the podcast and this is your first impression, I hope you like the crazy because woohoo, my brain, although I am finding the right medication, I'm still a bit weird because that's just who I am, and I don't want medication to take that away because that's part of me that I actually like. Like I said, try not to get sidetracked off the notes, but I'm already doing it. if you're new to this podcast and you haven't heard my previous episodes, I did 3 parts talking about my whole mental health nursing journey, but I didn't really get into medications in that. And on nursing placements, you need to do 2,300 hours worth of placement hours to qualify to be a nurse. When I was actually researching for this, I think they're trying to drop it down to 1,800 odd hours, so taking 500 hours off, which is one whole placement, which, although doesn't sound that much in terms of the fact that you're still doing nearly 2,000 hours, it is a lot, because you get a bursary, you don't get a student loan. £500-600 a month when I was at uni, given that was 5-6 years ago. I think it's maybe changed a bit now, but I was doing night shifts and going into uni classes. I was working Monday to Friday 9 to 5, and then doing a shift at the weekend where I worked 15 hours to try and make money to be able to live life. So it was very, very heavy, but waking up in the morning and going to placement and doing that at that time, it really gave me a purpose. I did a lot of growing personally during uni, but after my accident I started to grow in a totally different direction that started to take me further and further away from nursing, where I realised that the whole system would have to change for me to consider going back to being a nurse. There is an interest in potentially looking into accessibility of nursing for disabled people, but right now I'm trying to adapt to my life as it is, and I really don't want to rush myself. I want to do something that I am genuinely passionate about, and that's going to take a little bit of time, and I'm okay with that, because I also need to be able to manage my pain and things like that, so that I have the energy and motivation and desire to wake up and go to work and do these things. But if my disability is too much, it impacts on every other aspect of my life, so I don't want to rush things. However, after that little bit of backstory, let's get into talking about mental health medications. I'll tell you some information that I have got from my little book of knowledge, and some things that might come back into my head when I'm talking through it. Like I said, as a nurse, we didn't really learn about medications whilst in uni. So how did I manage to learn on the job? Whenever you get medications, there's a little leaflet inside that tells you about the medication you're taking, how to take it, how to store it, what the effects can be, and kind of what the side effects that can be experienced. I think I might have said that, I don't know. I'm not sure if this is just a UK thing. I feel like most medications in countries in the world will have leaflets or pamphlets that come with them. The only reason why I'm saying I'm not sure if this is just a UK thing, because I know like ads on American TV when there's meds, it's like side effects of this medication may include blah 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 and death. But we don't have that in the UK, so instead we get a little leaflet. I do hope you also get those leaflets in the US, because wow, if you're from the US and you watch me rambling on in Scottish, please tell me if you get these little leaflets in your medication down below in the comments. What I would tend to do when it came to doing medication rounds with different nurses, they would hand me the leaflets from the box of tablets, and I would go write them in my little book, and I would write what they were for, the side effects, so that it could get it into my head. I would do this because after being given the leaflets, maybe a few at the time, they wouldn't just chuck the whole medicine cabinet at you, because that would way overwhelm me, but would get given a few at a time. And then when it came to doing, say, the morning medication round, I would either be reading out the medication for one of the nurses to dispense it, or it would be the other way around, and whilst doing that they would say, okay, there's this medication, what is that used for? What is that used to treat? what can some of the side effects be? What is something that we need to look out for? Because although I was not a prescriber for medication, I had to know what meds I was giving to my patient, what they looked like in the cup, so that I knew after I had gone through and put the medications in that when I looked, I could look and say, yeah, that's right in there. And we were also wanting to look out for what kind of side effects might need to be monitored. And this didn't just include mental health medications, but I also had a baseline of knowledge of medications for physical and general health, because the majority of patients are not just on medications for their mental health, and this can be due to other conditions that the person has alongside their mental health, or things that have been prescribed due to side effects, and to help kind of decrease those. And I keep mentioning side effects because with medication, side effects can be fatal if they're not noticed or managed. Before, I know I kind of made a bit of a joke about the US and their adverts and may cause death, but I'm going to go on to talk about some different types of medications that I learned about, and one of them is clozapine, which is an antipsychotic that is usually only used when a patient has been treatment resistant to other antipsychotics, and this usually means that they will have tried 2 to 3, maybe 4 different antipsychotics before they are put on clozapine. And the reason I mention this medication now instead of just when I'm going through it is because this is a main medication that I think of when I mention side effects. Taking this medication and it being unmanaged is extremely dangerous, and one of the main things I would monitor as a nurse for patients that were on clozapine was their bowel movements. And the reason why bowel movements were monitored and using a stool chart was because if patients weren't able to go to the toilet, they would then need a laxative to help them go to the toilet, and this would need to be monitored because in cases people had to lose pieces of their bowel and be given stoma bags in place of that because of unmonitored side effects from the medication. So it needs to be really carefully monitored, and working as a nurse, that is part of your responsibilities. Even if you're not a prescriber, you should know the type of medications that you have in your trolley. You should know what you need, what it might interact with, and most places will have a BNF, which is your big book of drugs that will tell you interactions with other medications. As a nurse, technically we shouldn't be the one that is having to point out those things, because the doctors that are prescribing them should be saying, oh wait, sorry, I can't prescribe that medication because it interacts with another one. But people make mistakes sometimes, and there are other healthcare professionals that need to have a baseline knowledge so that when these mistakes are made, they're caught early and it doesn't end up doing massive damage to a patient. The point that I'm making in all of this, outside of the perspective of me being previously a trained nurse, if you're given a new medication, ask about the side effects, read the leaflet that comes inside of the box, and be careful. If the side effects are impacting your life to a degree where it is really impacting your quality of life, you're not really able to do the tasks that you normally do, don't continue to struggle, but also don't go off of it cold turkey. Get in touch with your doctor and see what other options are available, because if you end up taking yourself off of the medication completely, it can then cause worse side effects, which obviously we don't want. Let's break down some different types of medications that can be prescribed in the world of mental health. The route that they're given, in simpler terms, if it's by mouth or by injection, and I am going to start with more commonly known types of medication, and then I'll get into some lesser known medications and what they are used to treat when it comes to mental illness. We have antidepressants. There are two types of antidepressants. There are SSRIs, which are selective serotonin reuptake inhibitors, and serotonin is often described as a feel-good chemical in the brain that helps to regulate mood, and normally after serotonin is used up, it sends a message between brain cells, your neurons, and it gets consumed. That's not the word that I'm looking for, but that's the reuptake. So it's released and then taken in. SRIs block the reuptake of serotonin. That means that there is more serotonin in the brain between those neurons, which improves communication between brain cells instead of it all being soaked up and used too quickly, which means more serotonin available helps to reduce mood, and it helps to boost mood and reduce symptoms of depression over time. When starting to take SRIs, you will be typically told that it takes a few weeks, usually 4 to 6 weeks, to start feeling the full effect of the medication because your brain needs time to adjust to the higher serotonin levels. There are currently 8 types of SSRIs that are prescribed in the UK. These are citalopram, duloxetine, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, and vortoxetine. And I'm not even going to read the brand names of these, because I would just end up getting myself mixed up. But the cautions that can be given with SSRIs. I'm having to chop lots of bits of this up because I just keep messing up my words and things like this. So if this is a bit choppy, don't worry about it. Just go with the flow. There are cautions given to people with antidepressants, such as SSRIs, and you may not be able to take this medication if you have bipolar disorder and you are in a manic phase. Although it can be useful for depressive phases, it can kind of make a manic phase go on longer, I think. You shouldn't take SSRIs if you have any type of bleeding disorder, if you have type 1 or type 2 diabetes. If you have epilepsy, SSRI should only be taken if your epilepsy is well controlled, and if it gets worse, then these SSRIs should be stopped. Serious kidney or liver or heart problems, if there are any kind of warning signs for these problems, you should be monitored regularly by your GP whilst being on SSRIs. And you may also be at risk if you have narrow angle glaucoma, which is a common eye condition where the optic nerve which connects the eye to the brain becomes damaged. Wow, that was a lot of words. I think I actually managed to get through that without messing it up too much, but there was a bit of noise outside which kind of distracted me. So there are then SNRIs, which are selective serotonin and noradrenaline reuptake inhibitors, and these are used to treat major depression and some other conditions. They are newer than SSRIs, but they work in a similar way by increasing the levels of neurotransmitters in the brain. SNRIs specifically target both serotonin and noradrenaline to improve mood and overall mental health. In the UK, there is only 2 common SNRIs prescribed, which are venlafaxine and duloxetine. Venlafaxine is available under different brand names such as Affixor, Venlafac and Winfex, and this was the first SNRI that was ever put on the market back in 1994. This medication is mainly used for major depressive disorder, generalised anxiety, social anxiety, and panic disorders. Duloxetine can also be known by the names of Cymbalta and Yentreve, and this has a couple of specific uses. Cymbalta is prescribed for major depression, generalised anxiety, and also diabetic nerve pain, whilst Yentrev is used to treat stress urinary incontinence, and it is important to note that these two versions of duloxetine should not be used together. Each one has a specific purpose. SNRIs may not be suitable if you have a history of heart disease or you have poorly controlled high blood pressure. There are some possible risks to taking antidepressants during pregnancy, which can include the loss of pregnancy, birth defects affecting the baby's heart, and the baby can be born with a rare condition called persistent pulmonary hypertension, which can cause breathing and circulation problems, which as a new parent, that is something terrifying to go through when you have a baby and you're worried about their breathing and circulation. Moving on to breastfeeding, paroxetine and sertraline are usually recommended as these medications are considered safe for breastfeeding. Other medications may be used, but it is under the discretion of your doctor and what they think would benefit you for a new parent and their baby. When taking antidepressants during pregnant, this is something that should also be monitored, as children can sometimes be born and experience withdrawal symptoms. There was actually a bit of new information that I learned today. When it comes to children, SSRIs are usually recommended that they should not be given to people under the age of 18, and this is because there's evidence of an increased risk of self-harm and thoughts about suicide in this age group, and there is also concerns that the use of SSRIs could actually affect brain development in children and younger people. Sometimes SSRIs can be prescribed to children, but it should only be in line with talking therapy and monitoring. Children should not just be given medication and fobbed off, which right now in the current state of the NHS, I wouldn't be surprised if that is what is happening because of the waiting lists to get talking therapy, but I really hope that they're still kind of doing it by the book. However, it's difficult. One of the other warnings when taking antidepressants is alcohol usually isn't recommended because it can increase drowsiness and it also may make your feelings of depression worse. I always used to kind of question when drinking when I was on antidepressants because I would think, well, should I just not take my tablet because I'm going to drink alcohol and that's a depressant, so if I'm taking an antidepressant I'm kind of taking two things that cancel each other out, when realistically I should have been thinking, if I'm on antidepressants, should I really be having the alcohol because that's going to bring the depressant in and make me more depressed. However, at that time I couldn't really see those connections and the alcohol seemed like it was the escape from my depression and not one of the things that was continuing my depression, which I think is a very difficult cycle to be in and why it can be so easy to slip into alcoholism without really realising it. Before I go on to speak about some other types of medication, I'm just going to run through some common side effects of antidepressants. So some common side effects can be feeling agitated, shaky, anxious, feeling or being sick, having indigestion, diarrhea, constipation, a loss of appetite, weight loss, dizziness, blurred vision, dry mouth, excessive sweating, sleeping problems, headaches, loss of libido, difficulty achieving an orgasm during sex or masturbation, and it can also cause erectile dysfunction in men. With taking medication, it is said that if you experience some of these side effects that they can improve over time, although some, such as the sexual problems that I mentioned, can be very persistent, and that can have a big impact on people's confidence and things like that. Some less common side effects of antidepressants can include bruising or bleeding easily, including vomit and blood, confusion, movement problems such as shakiness and stiffness, seeing or hearing things that aren't real, or being unable to pee. Some people have suicidal thoughts and a desire to self-harm when they first take SSRIs. Young people under the age of 25 seem to be particularly at risk. Contact your GP or go to the hospital immediately if you have thoughts of killing yourself or harming yourself at any time whilst taking antidepressants. It may be useful to tell a relative or a close friend that you have started taking antidepressants and ask them to read the leaflet that comes with your medicine. Ask them to tell you if they think that your symptoms are worsening or if they are worried about changes in your behaviour. And sometimes when you're in a dark place, it can be really difficult to accept these things without feeling like it's an attack. But I want you to try and think of and look at it as it's people that are caring about you and they want to look out for you and they don't want your health to get any worse. It's not an attack or it's not anything that you're doing wrong. It's just sometimes medications don't work for people and sometimes it can take a while. When stopping or reducing a treatment with SSRIs or SNRIs, withdrawal reactions such as anxiety, agitation and insomnia can happen. This has led to updated safety warnings, particularly for medications like paroxetine and venlafaxine, which seem to have a higher risk of causing these symptoms. Common withdrawal reactions can include dizziness, tingling, nausea, headaches, sweating, anxiety, and having sleep problems. It is really important for prescribers and patients to be aware of the risk and to stop taking medication suddenly. Gradually tapering off a dose over several weeks can help to reduce the severity of withdrawal symptoms, and it is always better to do it in a safe and effective way than to go cold turkey and punish yourself basically. Anti-anxiety medications. In the UK, medications for anxiety include both non-benzodiazepines and benzodiazepines. While buspirone is commonly prescribed in the United States for anxiety and depression, in the UK it is primarily used for stopping smoking. Instead, you might be prescribed pregabalin, which is typically a nerve painkiller, but it can also be used to help manage anxiety and epilepsy. Pregabalin is a prescribed medication used to treat epilepsy, anxiety and nerve pains caused by conditions such as diabetes, shingles or an injury. It works in different ways depending on the condition. For epilepsy, pregabalin reduces the abnormal electrical activity in the brain which prevents seizures. For nerve pain, it blocks pain signals that are travelling through the brain and the spine. And for anxiety, it reduces the release of chemicals that trigger anxious feelings. Pregabalin comes in tablets, capsules or liquid forms. While it is often used for epilepsy, it can also help with anxiety and pain even if you don't have epilepsy. It starts to take a few weeks to start working and there can be side effects such as drowsiness, dizziness and headaches, but these are usually mild and they will go away on their own. Pregabalin is only used for adults and it may not be suitable for people over the age of 65. It is important to let your doctor know if you have had any allergies, addiction issues, or are pregnant or breastfeeding, have kidney problems, or are on some kind of sodium or a liquid form sodium diet. Some common side effects of pregabalin can be headaches, feeling sleepy, tired, dizzy, diarrhea, mood changes, feeling sick, swollen hands, arms, legs and feet, blurred vision, difficulty with getting an erection, weight gain because it can make you feel very hungry, and memory problems. These tend to impact 1 in 100 people, and like I'd said, the side effects are usually pretty mild and they will go away on themselves by themselves. But like I said before, if a medication is impacting you to any level where you feel like it is impacting your quality of life, please tell your doctor if it's really bothering you or if it's not going away. If you have diabetes, pregabalin can upset your blood sugar control, monitor your blood sugar often for the first few weeks of treatment, and adjust your diabetes treatment if you need to. There are some serious side effects that come with pregabalin, and you should get a doctor and call 111 straight away if you have thoughts of harming or killing yourself. A small number of people taking pregabalin do have suicidal thoughts, and sometimes it is after only a week of treatment, so be very cautious in those first few weeks. You can get severe dizziness or pass out unconscious, where you should probably go to A&E. You may start seeing hallucinations, and if you start to have incontinence problems going to the toilet, constipation, having blood in your pee, these are all warning signs to look out for. The other big thing about pregabalin is that it is a classified drug because some people can become very addicted to it. If this happens and you start to have withdrawal symptoms after you stop taking the medication, even if you're not addicted to pregabalin, when it is time to come off it, it is highly likely that you will experience withdrawal symptoms. When you stop taking pregabalin, just like what I said with antidepressants, you'll need to reduce your dose gradually to avoid getting more severe withdrawal symptoms. Do not stop taking your medication without speaking to a doctor to safely decrease it first. Although I'm talking a lot about medication and there is a lot of advice on here, these are things that are online. Do not take my word as medical advice, because I am no longer a registered nurse. I am just a one-legged gal who is sitting and sharing her experience and knowledge. So if you have any of these things going on, speak to a medical professional, because I am going to kind of put a bit of a disclaimer at the start of this episode, because I realise it is quite a bit into it to say I'm not a medical professional. Maybe this will be a little flashback at the start, but yeah, not a doctor.
Not a doctor.
Pardon me. Not a doctor, but here are some other things that can help with your anxiety. For physical symptoms such as racing heart, sweating, the symptoms you like hyperventilate and the symptoms you kind of associate with physical anxiety, you may be prescribed beta blockers, such as a common one which is propranolol. And although this only addresses the physical sides of anxiety, it can be helpful even if it doesn't quite tackle the mental side. Benzodiazepines such as diazepam and lorazepam, which are brand names Valium and Ativan, are sometimes also used in the UK for short-term anxiety relief. These medications can ease both the physical symptoms of anxiety, such as tension, rapid heartbeat, and also the distress that is being caused in the brain. However, there is a high risk of dependency with these medications, and the withdrawal symptoms can be pretty rough as well, so benzos are usually only prescribed for short-term use. We're now getting on to the part of the episode where I'm starting to discuss some more serious medications. Antipsychotics are medications that are used to treat symptoms of psychosis, which can include hallucinations, seeing or hearing things that aren't there, delusions, which you are holding firm beliefs that don't match reality, and other disruptions in how a person interprets the world. These medications can help manage the complex symptoms of mental health conditions like schizophrenia, bipolar disorder, and schizoaffective disorder, sometimes even personality disorders or severe depression with psychotic features. However, psychosis isn't always linked to one of these conditions. Sometimes people can experience psychotic symptoms in isolation, which still makes them a candidate for antipsychotic treatment. Antipsychotics are designed to help people experiencing psychosis feel more in control of their lives. For many, psychotic symptoms can be highly distressing, so managing them through medication can offer relief and improve day-to-day functioning. In fact, there has been research from the Royal College of Psychiatrists that suggests antipsychotics can be highly effective, with 4 out of 5 individuals with severe mental illness benefiting from these medications. However, since everybody's brain is different, that may take some time and experimentation to find the right medication, dosage, or combination that works for particular individuals. And sometimes when people are struggling, they don't have it in them to go on a medication, reduce off it, go on to another medication, reduce off it. And I think that's why when I worked as a nurse, I saw a lot of antipsychotics being started and monitored in the hospital, because it was better to get them at a dose where they were then able to live their life safely in the community than start a dose and send them home and just hope that they'll continue to come back, if that makes sense. How do antipsychotics work? Antipsychotics primarily work by targeting a brain chemical in the brain called dopamine, which is believed to play a key role in psychosis. High levels of dopamine may disrupt how the brain processes reality, leading to symptoms like hallucination or delusions. By blocking dopamine receptors in the brain, antipsychotics can help to reduce the intensity of these symptoms, making it easier for people to distinguish between reality and their altered perceptions. For people with schizophrenia, the evidence shows that antipsychotics are often the most effective treatment. Other mental health conditions such as bipolar disorder, particularly in manic phases, and severe depression with psychotic symptoms, can also respond well to antipsychotic treatment. However, it is important to note that antipsychotics do not work instantly. Like antidepressants and other medications, it takes time for your brain to adjust to these medications, so it may take days or weeks to start noticing a reduction in psychotic symptoms like hallucinations or delusions, and it can take an even longer time for the full effect of the medicine to become totally apparent. There are 2 different types of antipsychotic medication. You have typical first generation antipsychotics, and then you have atypical second generation antipsychotics. Typical first generation antipsychotics have been used since the 1950s, and these are considered to be an older class of antipsychotics. Some common examples include chlorpromazine. I used to know how to say this medication and it's just coming out so wrong. Chlorpromazine, haloperidol and flupentexinol. wow, I butchered them, but I tried my best. First generation antipsychotics are effective at reducing psychotic symptoms, but they tend to have a higher risk of side effects related to movement, such as tremors, becoming rigid, and other symptoms which can be grouped under the term extrapyramidal symptoms. These side effects occur because the medication blocks dopamine in areas where the body regulates movement. Atypical second generation psychotics were introduced in the 1990s. These medications are considered to be newer and generally have fewer movement-related side effects than typical antipsychotics, although they may come with their own risks such as weight gain or metabolic issues where it slows down your digestion or speeds up your digestion. Some examples of atypical antipsychotics are risperidone, olanzapine, quetiapine, and aripiprazole. See, those flew off my tongue because I know them better. I know haloperidol and flupentixol, but that other one, chlormazepine, oh my god, I don't know. I feel like I just got that right when I said it there, but now I'm looking at the word and it's not looking right. Anyway, atypical antipsychotics also block dopamine, but in a more targeted way, which reduces the risk of movement-related side effects. However, they can cause other issues such as metabolic syndrome, weight gain, and sedation. One particular atypical antipsychotic is one that I mentioned earlier, which is clozapine, and this is often reserved for individuals who have not reacted well to at least 2 antipsychotics. Clozapine has been shown to be highly effective for treatment-resistant schizophrenia. However, it does require regular blood tests due to the risk of agranulocytis, which is a rare but serious condition where white blood cell drop, and it makes it easier to develop infections. I hope that made sense because I said white blood cell drop instead of white blood cell count drop, but you know now. Like all medications, antipsychotics can come with a range of potential side effects, which can vary depending on the individual and the specific drug that is being taken. The most common side effects include movement-related side effects, which are the extrapyramidal symptoms. These include abnormal muscle movements such as tremors, muscle rigidity, involuntary movements. First-generation psychotics are more likely to cause these issues, but they can also occur with second-generation antipsychotics as well, although it's less frequently. There are metabolic effects. Many atypical antipsychotics are associated with weight gain, increased levels of cholesterol and glucose, leading to a higher risk of conditions like diabetes and heart disease. Regular monitoring of weight, blood sugars and cholesterol is recommended for those that are taking these medications. And hyperprolactinemia is elevated levels of prolactin, a hormone which can cause side effects such as missed period in women and enlarged breasts in men, and sexual dysfunction in both sexes. There can be sedation, feeling excessively sleepy, fatigued. That is often a side effect with quetiapine and olanzapine. It can be beneficial for those who have agitation or insomnia, but it can be very problematic for those who need to stay alert during the day. There are anticholinergic effects. Some antipsychotics can cause dry mouth, constipation, blurred vision, and difficulty urinating due to their anticholinergic properties. There is risk of neuroleptic malignant syndrome. This is a rare but potentially life-threatening condition, and this can occur with all antipsychotics. Symptoms include fever, muscle stiffness, confusion, irregular blood pressure or heart rate. If this is suspected, immediate medical attention is necessary. There is a risk for weight gain and diabetes, like mentioned previously. Weight gain is a significant concern, especially with second generation antipsychotics like olanzapine and clozapine. This can increase the risk of type 2 diabetes and other metabolic conditions, so monitoring is really important. The last one I did see some of as well, and that is tardive dyskinesia. This is a serious side effect which is associated with most long-term use of first-generation antipsychotics. This involves involuntary repetitive movements, often the face and the tongue, and in some cases these can become permanent. Antipsychotics can be administered in various forms, including tablets, liquid, and long-acting depot injections. Depot injections may be beneficial for people who struggle to take medication consistently, as these are administered every few weeks or months, depending on somebody's care plan, by a health professional, either at a clinic or they come out to your home and do it. Doctors should be discussing your preferences for how you want to take medication and tailor your treatment plan accordingly. It is crucial to take the medication as prescribed, even if you don't feel better immediately, as it may take time to work, and that is also if you start to feel better, because the medication needs to work, and sometimes if you stop it, it's just going to cause you in a spiral. However, if you do decide to stop taking antipsychotic medication, it is essential to do so under medical supervision. Suddenly stopping antipsychotics can lead to rebound psychosis, where symptoms return rapidly and may be even worse than experienced before. Withdrawal symptoms can also occur, which vary depending on the specific medication. Your doctor will typically help you taper off medications gradually, which will help to minimise these risks. Because antipsychotics can affect your physical health, particularly your heart and metabolism, regular health checkups are crucial. If you are taking antipsychotics, your doctor may recommend annual or more frequent health checks, including ECGs to monitor your heart and checking your blood to test for cholesterol and blood levels. For those with severe mental illness such as schizophrenia, GP surgeries in the UK often have a mental health register, which ensures that people that are on antipsychotics receive regular physical health checkups. If you have concerns about your physical health while taking antipsychotics, it is essential to raise these with your GP or your psychiatrist. Antipsychotics can play a crucial role in managing psychosis and other mental health conditions by helping to reduce symptoms such as hallucination and delusions. Whilst they can be highly effective, finding the right medication may take time and side effects can vary. Regular monitoring and open communication with your healthcare provider are really key to finding a balance of the benefits and risks of antipsychotic treatment, and it should be always your choice whether you want to take meds or not. However, under certain mental health detentions, you may be started on medication where your consent isn't really thought of because you're detained and it's the best thing for your health at that possible moment, but that's not something I'm talking about today. If you want to hear more about that, maybe I'll do an episode on the different types of detention and what that means for your rights and things like that. That might be an interesting episode to do. Let me know your thoughts. However, I am going to go on to some more commonly prescribed general medications. I am nearly finished going through the different types of medications that are in mental health. However, in my little notebook, I have other medications that are more general, but they do come up quite a lot, and they were prescribed alongside mental health medication. I have an episode that I am not sure when it is going to come out, but it will take a lot of planning and it is a lot to think about. But as a mental health nurse, I had to look after patients as whole people. They weren't just mentally ill, they had physical conditions alongside that. And what I want to discuss in this episode that I'm thinking about is the other side of the coin with my experience and of others being in general hospital wards and the mental health being very low on the priorities as physical health is our job. I'm not sure if that makes sense in the way that I'm saying it, but hopefully in time when I have a full episode, it'll be a bit clearer, and maybe I'll throw that other idea in there that I just mentioned literally 2 minutes ago that's already gone right off the top of my head. But anyway, back to the point of this episode. These other medication types are meds such as painkillers, antiarrhythmics, antibiotics, anticoagulants, anticonvulsants, antihypertensives, antihyperglycemics, diuretics, supplements, laxatives, proton pump inhibitors. And I know that they're quite medical terms and some of them might sound weird, but I am going to quickly run through what these medications are. Painkillers can include opioids and non-opioids. That is things like paracetamol, ibuprofen, aspirin, naproxen, codeine, tramadol, morphine. When using antidepressants, I think I have maybe mentioned it before, but you need to be careful when taking ibuprofen as it can interact with mental health meds. Antiarrhythmics are a medication that suppresses abnormal heart rates. These medications are such as bisoprolol and digoxin. These medications can also help to treat or prevent heart failure. There are then antibiotics, which I feel like don't need a lot of breaking down. There are lots of different types of antibiotics in hospital settings. Swabs or bloods will usually be taken to see what kind of bacteria is floating about and what kind of antibiotic they're going to give you that isn't treatment resistant to some kind of antibiotic. And I think that's why there's been such a clamp down on medications and giving out antibiotics, because you don't want people's bodies to get used to antibiotics where they then start getting infections and they have to use different antibiotics because it's resistant kind of thing. Anyway, like I said, not a doctor. I just have an interest in medications, okay?
Not a doctor.
Anticonvulsants are medications that are used to help treat seizures. The most common one I saw prescribed was sodium valproate, which were pretty chunky tablets, or they were at the time. Anticoagulants, these are medications that reduce or stop blood clotting. This may be something like warfarin, or after surgery people are usually given jags in their stomach, which is a Prixban, I think. I hated doing them on myself, and I'm just kind of starting to ramble on about other types of medication now, and you know what, I am just gonna stop. So anything I have said about all of these medications, if you're interested in hearing some more about things that I've mentioned, drop me a comment, send me an email, anything. I'd love to hear from you. However, there is one very important thing that I am going to touch on before I go on to my experience and wrap up this episode. I know it's been a bit of a long one, but do you know what? It's worth it. So St. John's wort. Be careful. St. John's wort, or hypersum perforatum. Latin words, is a flowering plant with a long history of use, especially in Europe, for various mental health conditions, particularly in depression. In the United States, it is sold as a dietary supplement, but it lacks the strict regulations that govern prescribed medications, meaning that the quality and concentration can vary widely. Many people will seek out St John's wort as a natural alternative to traditional antidepressants. It is believed to help improve mood, alleviate feelings of sadness or hopelessness, and particularly it is for those dealing with mild to moderate depression. There has been some research done on St John's wort's effectiveness for depression, which shows some mixed results. A 2011 clinical trial found that neither St John's wort nor the antidepressant citalopram worked better than a placebo for minor depression. In a 26-week study, St John's wort, sertraline and a placebo had similar effects for moderate to major depression. There was a 2008 review that suggested that St John's wort may outperform a placebo and be comparable to standard antidepressants for mild to moderate depression. This was a study that was particularly conducted within German countries. However, there was an earlier 2002 study concluded that it was no more effective than a placebo for moderate to major depression. So there are some things there that kind of conflict, but I mean, the latest trial was 2011, which is still a while away, back the way, that neither a citalopram or a placebo worked better, which is wild. Makes sense why citalopram never really worked on me, but I'll get into that in a minute. Whilst St John's wort may offer some benefits, it is essential to be aware of the potential risks. Serotonin syndrome, combining it with certain antidepressants, can lead to dangerously high serotonin levels, resulting in symptoms such as agitation, rapid heartbeat, and hallucinations. It can worsen psychotic symptoms in individuals with bipolar or schizophrenia. There are a lot of medication interactions with St John's wort, and it can, and these medications can include antidepressants, birth control pills, cyclosporine, which is for organ transplants, and warfarin for blood thinning. So like I said, please be very careful if you are taking this medication and any other medication. Side effects of this are an upset stomach, dry mouth, headaches, dizziness, sensitivity to sunlight, and it may also worsen some people's anxiety. St John's wort should not replace conventional care. If you're struggling with your mental health, please speak to a doctor instead of delaying treatment. Dietary supplements can cause health problems if they're misused, especially when combined with other medications. So please, if you are prescribed anything and you're taking St John's wort or you're thinking about taking it, please speak to your GP first. I'm going to go on to my medication experience, and then I'm going to end it on rambling today because I've been talking for a while. My mouth is getting dry. I'm getting hungry. It's time for some food. But first, I'm going to have a drink of my water. Remember to stay hydrated, and I'll share my experience, and then we're done for this episode. I am not sure how much of my experience I've kind of shared with mental health medication in the past through the last 29 episodes of this podcast. However, when I first went to the doctors, I remember my mum telling them that she didn't want me to be medicated, and I later found out she was on antidepressant medication, and it did feel a bit hypocritical at the time, but now knowing with research that antidepressants can impact the brain development of younger children, and there is a higher risk of suicidal ideation and self-harming in people under 25, like, I'm kind of glad that decision was made, even if it wasn't for that reason at that time. I first started to try medication for my mental health when I was 18, just turning 19. And I remember going to the doctors and telling her that I was actively suicidal. I didn't just have one plan, I had many, and I don't outwardly want to say any of the ones, as I'm not going to give anybody any ideas. Anyway, at this, I nearly ended up getting hospitalised as she phoned the crisis team. I got sent away to pick up some antidepressants, told my dad, and then he took me back to the doctors and they started talking about getting me admitted to hospital, where at this point I was already training, I'd already been on placements. I saw what admission wards were like and I knew that would make my brain so much worse, not better. I was like I said, I was referred to the crisis team and I was put on fluoxetine. At this time, I was working behind a bar, and I think it was one of my first shifts. And this medication was giving me serious tremors where I was just shaking so badly, and I felt so embarrassed trying to pull pints and spilling them at the same time. Also in my mind, putting myself down and shaming myself because I was costing my boss money and the tremors were just getting worse. And the mental health nurse came to my house and would spend 10 minutes maximum in my house, have a look about, and then say, right, see you next week. I didn't get anything from it. I don't think he really got anything from it. And that's not really helpful when you've told a doctor you want to die and you've been put on antidepressants, especially now with the knowledge that I was 18, 19 and there is a higher risk of wanting to die when put on antidepressants. Anyway, around about 4 weeks of being on fluoxetine, this CPN came out to see me and I said, I'm shaking, it's fucking me up at work, I feel awful, I want to die. And he said, oh, I was actually going to discharge you today. I guess I'll come out and see you next week. So I went back to the doctors, I got changed onto citalopram. He came out the next week, he said, I'll send you a letter in the post. Never saw him again. I ended up having an appointment with the psychiatry team, which also wasn't a very helpful situation because each time I would go to see a psychiatrist, it would be a different psychiatrist, and I would have to go through all of my history again, and it felt like they didn't really care how I was doing mentally. They just wanted to know if my meds were working, and I didn't find it helpful at all. However, I continued to take citalopram for roughly around 8 months before I started to feel very suicidal again and wanting to harm myself. And on my medical record, it probably noted that I went back onto citalopram after because I had wondered for a while if it would be seen as me being treatment avoidant because I was told that I had to be medicated to go on placement. I was perceived as being too unstable to be on placement without being medicated, which sucked, by the way. But I went to the doctors, I picked up the box, I took it to uni, I said, here's my meds. Didn't take one of them, and guess what? I fucking coped. I wasn't too unstable to be on placement, but that's what it is. I just needed to show the prescription, and yes, it is a bit shitty. I probably shouldn't have done that, but I was fucking desperate. I was coming to the end of my uni training and you're telling me, okay, either get these meds or you're not going to graduate. Like, bet, prescription, I won't take them. So that was not the best experience to start off with, and it did leave a bit of a bitter taste in my mouth towards being medicated. And I think that's also because there was shame on my part, because I didn't want to ask for medication and for them to say, well, you didn't stick to it last time and you got these meds and you didn't take them and you did this and you did that. However, I have recently made the decision to try medication again in line with talking therapy, as I am trying to put positive things into place, and I am realising that I need a little bit of help with my brain chemicals, because I live every day with mental illness, and that's okay. It has been a rough few weeks. I was on duloxetine for pain. This was prescribed to me quite a while ago, and I was on 30 milligrams, which is a very low dose. Mental health dosage starts at 60 milligrams. Duloxetine can interact with a lot of different antidepressants, so it was decided initially that I would increase my duloxetine. So I went up to 60 and it wasn't helping. I went up to 120 and my tremors were really bad, and the fatigue that I was getting from it was awful. I was so tired, so much brain fog, sleeping 13 to 17 hours 3 days out of the week, like really massively having an impact on my life. And I am now coming back down off of this medication, and the cloudiness in my brain is kind of lifted. The fatigue's feelings have definitely lifted. Like, I've reduced my medication and I have been able to plan 3 podcast episodes, record 2 of them, whereas when I was on that high dose I didn't really feel like I could do anything. So I am feeling a bit alleviated, but I still feel like shit. I still feel like an emotional wreck, like trying to give compassion to my inner child and just bawling my eyes out because I wish I'd done it sooner. And that's a really hard thought to combat in your mind, because I can't have done it sooner and I'm doing it now, and that's the important thing. But on those days where it's feeling really rough, that voice where it says, yeah, but you're doing it now, that's still very quiet in my brain. And I do feel like I'm still losing track of time. I'm forgetful. I have brain fog. I tried to take a few hour nap the other day and it turned into a 5-hour nap. But sometimes that's just because I'm disabled. I'm tired. I'm fatigued. Sitting here, I've been sitting recording for nearly an hour and 20 and I'm in agony. My heat patch on my back is no longer really helping. I can still feel the warmth from it, but I feel as stiff as a board, and that's a lot. However, back on to my experience with antidepressant medication. I have a plan right now with my doctor to safely decrease off of duloxetine and then do a straight switch onto a low dose of venlafaxine. She then also agreed with me to check in with me 6 weeks, 8 weeks or something after we'd had this phone call, so that I put in my diary when I'm decreasing and when I'm starting, and then she'll speak to me the first few weeks of me taking the venlafaxine, and that's when we'll decide, how am I feeling? Do I feel like I should increase it? Do I want to see for a bit more and then maybe speak to her in 4 weeks? It's just seeing where we're at, and I feel like it is very much a journey right now, and one that hasn't been easy. I've felt a lot of resistance in myself, like that little devil on my shoulder saying, are you sure you need medication? Things aren't that bad. You're weak for needing medicated. But then I've also got that angel on the other side that's getting a bit more confident in herself to say, no, you do deserve help. Medication doesn't make you weak. If anything, it makes you stronger. And I think that's a sentiment that I'm going to end today's episode on. Thank you so much for listening to me ramble on about one of my passions when it comes to nursing. Like I said, I am hoping to do some episodes on some different mental health things, some different conditions, a bit of education around them, and maybe also experiences from social media, because I wanted to put in some different voices other than me today, but you can tell by the length of the episode that just wasn't happening. So yeah, you know what? I realised I had a lot to say and I got on a roll, and you know, if you want to hear other people's experiences, I'll do a part 2 and I'll talk about mental health conditions and medication and hear other voices and just whatever, maybe just have a little chin wag, who knows. If you want to tell me your experience of mental health medication, treatment and mental health services, if you've been admitted, anything you want to share with me, drop a comment, email me at cripplecroniclespod@gmail.com, or you can drop me a message on socials at cripplecroniclespod on both Instagram and TikTok. If you're new here and you have made it to the end, please subscribe if you've enjoyed this episode. Add it a like, give it a like, add it to your little podcast rotation. If you've enjoyed this, just rate it, tell your pals, share it about. It would mean the world to me. Sending you lots of love. I hope you have a fabulous week or two, and I'll see you in the next episode. Bye!